so much. First, I would like to thank the HSHC for inviting me to talk in this lecture series. It's my pleasure to share our findings based on a community-based research that I initiated about 10 years ago. So it was almost 10 years ago that after I joined the University of Alberta, the first project was initiated, and eventually last year in 2019, it turned into like an education tool that is available to anyone, to public who wants to use it. So yeah, it took almost 10 years, and I hope you find it interesting, because my intention is not to go through every single project, because this is a series of the project with a final product. So I just wanted to show you how one, like sometimes even informal communication with a researcher colleague or a community collaborator can turn to something that would be sustainable and beneficial to the community. So I'm not going through all the details of each single project, more like looking at the overall project from A to Z. Before starting the presenting the projects, and I know many of you are very familiar with these names, because sometimes when we want to present our research to the non-dental community, which really bothers me, we have to justify ourselves by giving like all these numbers instead of like focusing more on the importance of the research and the findings. But anyway, like that's a habit. So I'm going to start with giving you some numbers that show why oral health is important, and why we spend a lot of time, effort, and energy to resolve the oral health inequalities. So more than half of the population on Earth, which is 3.9 billion people, they are suffering from some sort of oral health diseases, either dental caries, periodontal disease, oral cancer. And then among them, I can say like 60 to 90% of the children and almost 100% of the adults, they suffer from dental caries in one stage of their life. But to be more specific, 35% of the global population, they suffer from untreated dental caries. And to the point that dental caries is the most common chronic childhood disease, not only in North America, not only in developing or like countries, but also like in the underserved communities in developed countries. Again, some more statistics. 5 times the prevalence of dental caries is 5 times more common than asthma, 4 times more common than early childhood obesity, 20 times more common than diabetes. And these are some chronic health conditions that are prevalent among children. It is even more bothering to say that the disease, 80% of the disease is found in 20 to 25% of the population, primarily from low-income families, ethnic minorities, and aboriginals. So I think in the previous presentations, Dr. Shurat and the team showed you some of the results based in Canada on the provision of dental surgeries under general anesthesia, or like Aboriginal oral health. So the focus of my research or my presentation today is more on ethnic minorities, which are considered as high risk for development of dental caries, and also the rate of the usage of dental services in this population, especially the newcomers, is lower than the general population. To the point that in 2014, the Canadian Academy of Health Sciences, so it's not dental health, it's health sciences, recognized that vulnerable groups living in Canada have the highest level of oral health problems and the most difficulty accessing oral health care. So whatever we are doing, it's not working. And it's not, or maybe not it's not working, it's not efficient, it's not like the model of providing dental care at the moment in Canada does not work for all vulnerable populations. That's why instead of using a biomedical model, and that's what we are doing so far, we have to switch our kind of our paradigm. We have to shift our paradigm in the management. Instead of just focusing on fixing the problem, we have to focus more on prevention, because simply 90% of dental caries in underserved population is untreated. So if you want to develop a restorative, or if you want to have a restorative approach, it's just simply financially, economically, and manpower is not possible. We cannot really do follow like a treatment or restorative approach for 90% of untreated dental caries in vulnerable population. So that's why we have to collaborate with the community. We have to use their social capital. And we have to empower them to get help from them, because as a profession, if we were going to be successful, so far we could. So that's why we need to involve the communities and develop more community-based interventions that are more cost-effective, more sustainable, and then particularly we can target the high-risk populations. I like this kind of visual way of switching from fixing to prevention. Like we have to start, instead of continue mopping, we have to start turning off the tap by just focusing more on the prevention. I like this quote from late David Lockyer, who is one of the most influential dental public health specialists in Canada, that we have to shift from highly skilled technical activities to contemporary healthcare profession. After all, we are part of healthcare, and we are not just, like the fixer, and we have to stay away a little bit from, while we are working on all these aspects of the profession of dentistry, but we also need to have a little bit more focus on the healthcare aspect of our profession. But how much we know, like how much the modern dentistry has known or has addressed the social influences on oral health. By social influences, I'm talking about structural barriers, poverty, which directly affects on access to dental care, because dental cost is mainly provided by the private sector in Canada. Also, the psychological aspect, like, for example, the personal behavior, the attitude towards the importance of oral health, perceived need, to what extent people think that they need to have regular dental visit to make sure that they are not going to suffer from any type of oral diseases, or to what extent they know how to navigate the oral healthcare system, which refers to oral health literacy. And then the next aspect is psychosocial determinants, like the interaction between social determinants and psychological determinants. I gave you one example, like for example, if someone is suffering from poverty, and then they don't feel confident or they have low self-esteem in taking care of their own or their children's teeth, that causes stress. The stress itself can consider as a barrier to obtaining an optimal oral health for themselves or for their children. So with this thought, like about 10 years ago, we thought we have to start doing the community-based participatory research and to improve oral health of children among the newcomers, because newcomers are, especially in the first 5 years of their settlement in the host country, they are invisible in our society. So as a profession, if we want to approach them, or if we want to wait for them to approach us, it's not going to fail. It's not going to work. It will fail. So that's why we have to get the community involved if we really want to reach to this population. By community-based participatory research, we are talking about a relatively new approach in the research, which would involve the community from the first step. A CBPR is increasing recognized by community organizations, by researchers, even by policymakers, and it's an approach that in a respectful and equal manner would consider the expertise of researchers, academic, and also the community, and in all aspects of the research, from the beginning, identifying the burning issues, the needs for the community, and also how to formulate the research question, how to extract data or collect data from the community, how to generate the results, and how to interpret the results and make some recommendations for policy making. So as you see, it's not like the researchers would go to the community and tell them, I know better than you that this is what your community needs. I know how to fix it, and you are going to be dependent on me to fix it, even if we reach to the point, because most of the research ends once we get our data, our results, our findings, and then we move on with our academic life, publishing papers, talking in scientific communities, and talking with each other, not even thinking, okay, now we created this knowledge, how this knowledge should be mobilized and should be translated to action in the community and among the policymakers. Another beauty of the community participatory research is you not only involve the community from the beginning into the research, you also involve the policymakers, so they know exactly what the problem is. By the time that we reach to the point that we want to make some policy change, then they are involved, they feel the owner. So it's not only the community feeling the ownership of the generated data, also the policymakers feel like, okay, they were involved, they understand the situation, and they have some recommendations in hand how to fix the problem. So the big general, like the general research questions that we formulated was, first of all, what is the profile of children of newcomers in Edmonton? The previous research was like 20 years old or 30 years old, while we know that the profile of immigrants in Canada is changing year by year. So we cannot really rely on the results that we have like from 20 or 30 years ago. We also wanted not to only understand the barriers to access to dental care among this population, also the facilitators, how we can take advantage of the social capital of the community to resolve the issue of access to care. And then if we are going to develop and implement some type of community-based oral health promotion, how feasible it is, how the community is willing to engage and also to actively involve in promoting any type of intervention. So we had multiple community organizations, especially settlement agencies like Mennonite Center, Catholic Social Services, Multicultural Health Brokers, Africa Center. So they really helped us to start this project, and we still work, like we have an ongoing research with at least a couple of them. Alberta Health Services and Alberta Health, they were also part of the project from the beginning. The project was designed as a sequential mixed method approach. By mixed method, we wanted to do both qualitative and quantitative research to have rich information to take advantage of the strength of each method and provide rich information for this community. So that was actually the community's suggestion to start our research with a qualitative method with the health brokers. So the health brokers in multicultural health brokers cooperation, they work with different communities and they try to help them to navigate into the Canadian system. Not only help, they help with the education, employment, and including health. So we wanted to follow our research question, and with these aims to identify the barriers, facilitators, profile of children's oral health, and the feasibility of implementing an oral health intervention in the community. We conducted 4 focus groups with 20 health brokers from 13 communities. I facilitated one focus group, but then I noticed that as a healthcare provider, sometimes it's hard, they cannot openly express their opinion and concern to me. So for the other focus groups, I asked one of the community collaborators to facilitate the focus group, and it was really rich. Really, we got a lot of information from these focus groups. So as you see, we had representatives from Middle East communities, East European communities, South Asian communities, Latin American communities. So like a wide range of communities participated in this part of the study. Overall, we learned about the issues related to oral health beliefs of each community as a whole, and then baby teeth, more specifically, the barriers that they perceive to access to dental care, and what would be their recommendation for the future research. Very briefly, I talk about the barriers. Oral health was not a priority for this population, which is understandable when they have some burning issues like food security, like education, like employment. So, but they also mentioned that many of the newcomers, the dental care is a luxury for them. Even back home in their own country, they didn't have enough kind of infrastructure or resources to take care of their children's teeth. And of course, income, dental insurance, being hard to take off from the work to take your children to the dental office, or like transportation, there were some barriers they mentioned. And of course, for many of them, even before arriving in Canada, they had extensive dental caries in children. We identified some specific barriers for refugees. For example, English skills was a problem for all newcomers that we included, but For the refugees, it was even worse, and not to mention that because they suffer from low literacy in their original language, so sometimes even translation doesn't work. And then we have limited interpreter services, and then a large number of children living in household. Transportation is an issue, and that's something that we heard, that some dentists, they are reluctant to see refugee children for any reasons. And of course, dental coverage was a problem. So after we heard from the health brokers, we wanted to firsthand hear from the families what is their problem or their limitation or barriers to access to care. So this time we focused mainly on two more established communities in Edmonton, one South Asian, one Chinese, and one more like emerging community, like African community. We had 15 focus groups with 99 participants. We only focused on families with children 3 to 5, and we limited our population to families who had lived in Canada for only 5 years. So that was the main, the most important years to kind of, if we want to do something, then we have to identify the high risk group, and they are the highest risk at developing dental caries. And then we developed the interview guide based on the literature, also based on what we heard from the brokers. And we analyzed the data, and that was our overall conclusion. First of all, there were some visible differences between each community. So we reached to the same conclusion that one size does not fit all. If you want to develop any community-based research, it has to be customized to the need of the community. We also identified that the community needs some type of intervention that would increase the oral health literacy, that would increase their specific skills, like for example, oral hygiene skills or diet. And then there are some environmental constraints that would avoid them from reaching to the healthcare providers. So one way to eliminate or at least reduce this environmental constraint is to go to the community instead of wait for them to come to us. And then also, because dental health or oral health is not their priority, so the intention of some of the interventions is to raise public awareness about the importance of oral health of children. So we published 2 papers here. I briefly just give you a snapshot of each project, but if you are interested to learn more about this project, you can just refer to our papers. So now with the 2 qualitative projects, we learned enough to hear from a bigger population, because as much as I love qualitative research, I'm a qualitative researcher, and I don't even want to say like that's a limitation of qualitative research. This is the nature of qualitative research, that we cannot generalize the data because we just deal with a small sample. So for the next study, we designed a cross-sectional quantitative, and we also wanted to not only look at the some of the variables that we explored in the previous qualitative research. We also wanted to document the oral health status of the children. Anecdotally, children had lots of caries, but we wanted to make sure that this is true. And of course, for the future research, we needed to document it. So based on the the overall objective was, first of all, we wanted to look at the oral health status of the children. We wanted to see how aware parents are on their child's oral health, about their child's oral health, what are their perception. And even though like we think that parental awareness or their oral health perception would affect children's their own dental status and dental visits. But is there like a scientifically a statistical correlation between these two variables and oral health status and children's attendance or not? So our participants were children under 6, so our focus was more like early childhood caries and children under 6. However, we couldn't limit our participants to under 5 years of living in Canada because, as I mentioned, this population is kind of hard to reach. And for a cross-sectional study, we needed a bigger sample size. So we increased it to 10 years, which is still, we believe that many of the struggles in the first 5 years wouldn't go away in the next 5 years. So like increasing to 10 years would not really make that much of the change. And we went to the community locations. The community participants were the one who organized the events, and then they identify a location, they recruited the participants, and they helped us with data collection and administration of the questioning. And of course, we did the dental examinations. What we learned, so a total of 314 pair of parents and children were included in the study. The number of children was much higher because many families, they came to our events with like a number of children, 2, 3, 4, 5, even like 7 children in one family. And however, in order, for the sake of the research, we only included the data from the youngest child in our study. The mean duration of living in Canada was 4.6 years. The mean age for children, 62 months. 40% were born in Canada, so still 60% of children were foreign born, and then 63% of them, so even remember the age group under 6, 63% of them had high like untreated dental caries. And even though half of them had dental insurance, but only 43% had a dental visit in the past year. So among the predictors, among the variables we looked at, only 2 variables could predict dental attendance. One was dental insurance, which is understandable. The other one is longer duration in Canada. So families who lived in Canada longer, they were more likely to see a dentist for their child. As far as the family, more than half of the participants, they were highly educated. However, the income was less than 3,000 for, again, more than half of them. The immigration status, the majority of them came through family or business class. However, we had almost 1/3 from refugee class. And as we expected, half of the parents were not aware of their child's oral health condition, but we couldn't find any statistically significant association between parents' awareness and children's dental status or dental attendance. And when we looked at the perception, first of all, some parents, they said, I have no problem. I have insurance. I drive. I can take my child to a dentist. Language is not barrier, but I didn't take my child to a dentist because my child didn't have a problem. So perceived need was the motivator, the main motivator for many parents to take their child to the dentist. And of course, some of them, they talk about their own past dental experience, which was painful. So they assumed that the treatment or the appointment could be painful. That's why they were hesitant to take their child to the dentist. And many of them, there was trust issue. So they felt like if they go to the dentist, they do something to their child, then they have to go back. Which of course, like if we ask them to come like every year for polishing and fluoride, that's what we do. But that shows the distrust between the community members and the dentist. And then when we, again, statistically, when we looked at the variables to see which one was the predictor, the belief that a checkup is painful reduced the odds of a dental visit by 67%. So if the parents had a bad experience of dental visit, then they also they wouldn't take their child to a dentist either. So our conclusion from this was, as the literature showed, children of newcomers, they are at high risk to dental caries. We need to be culturally competent in terms of providing dental care to the children, because if we are not culturally competent, then we cannot provide some acceptable and feasible recommendations to the parents. People are not aware of the early screening and the importance and the benefits, so they have to be there should be some level of public awareness, and we need to have more intensive preventive measures, because access to care is an issue for these parents. So now, so what? Like, now we learned all of this, we collected all this information. If you don't translate it to knowledge, to the intervention, then there is no point doing it. Our research showed that we need to develop and implement a culturally appropriate educational program that has a meaningful communication, that can meaningfully communicate with the collaborators, I mean the communities. Therefore, we developed an educational tool. So it was a group of us, like the dentists, clinicians, also researchers, students at different levels, like DDS students, dental hygiene, even like undergraduate science students and graduate students. We had a number of meetings together. We looked at the current knowledge of the field. We also looked at our own findings. And then we developed an educational tool with 4 components. Then we applied for CIHR. We got a grant from CIHR. So we disseminated this educational tool among the community collaborators and also the AHS, Alberta Health Services administrators and community workers or leaders. The educational tool had 4 components: 1, oral health knowledge; 2, diet; oral hygiene; and dental visits. And this is a picture of like our dissemination. We grouped all the participants into 5 or 6 groups. It was 30 participants, and for each group we had 2 from our own team. We presented all the materials to each group, and then in a focus group we collected the data. We collected their input. What do they think about what we created? And then we adjust it, and then now we wanted to implement and test it. So we developed a workshop with the African community. This was more like a pilot with just 1 community. The workshop was a 3-hour workshop, and we had PowerPoint slides based on the educational tool we developed. We also had some hands-on training and some interaction with the community collaborators, and we also did it in different community locations. These are some photos of different workshops that we had, my team with the community. So now we did the workshop. So we need to see whether the workshop was working or not. Originally, we wanted to look at the short-term impact and also long-term impact. However, we had problem with the retention, so we just focused on the short-term impact. So we did a pre and post-intervention questionnaire using the theory of planned behavior. The components are, we measured the knowledge, attitude, perceived behavioral control, which is more like for the self-efficacy, and their intention to take the child to the dentist. Based on our results, we noticed that this workshop increased their knowledge significantly, improved their attitude. It also gave them the skills, at least, some skills to improve their self-esteem and perceived behavioral control. So, and eventually, the intention to take their child for a dental visit increased from 38% to 75%, which was statistically significant. So it worked. The population, the oral health education tool was working, and also the workshop was working. However, uh, we wanted to again, after the implementation, we collect more data. So we had one more focus group with 8 leaders, and because the leaders were part of the workshop as well, so we wanted to get their input, their feedback on the whole package on the intervention. Overall, they liked the tool. They gave us more impact, more comments or more input in terms of developing, in terms of the efficacy of the workshop. I don't know why my camera. Okay. And but they also gave us some additional information. So now, like, if we wanted to disseminate the intervention properly without the intervention being dependent on us going to the community, we had to make it accessible for the community so they can use it. Otherwise, the problem is still the same, the manpower, like the access to care, but in a different way. So that's why I was standing in Tim Hortons lineup to get my morning coffee, and someone from education technology was standing right beside me, and we were just talking because his background was education, and I said, yeah, we developed this educational tool. It took us like 8 years to reach to this point, and I am not confident to put everything online because, like, I'm not sure, like, all the photos that we use, all the material that we use, they are properly licensed, or like we have the permission. So as long as it was in the booklets, I was okay. But if we wanted to disseminate it in a wider range and make it publicly available through online resources, then I was not comfortable. So he said, okay, let's get an open education resource funding, and then we take care of it. We make sure that all images are legitimately open access, and we make sure that what the material that we include not only benefit the public, also benefit our own future generation of dentists, so they can disseminate it later on in their practice, and also the other faculties, they can use of it freely. So we started this project, which was new to me. It was not my area, but with the help I got from educational technology, and I hired one of our DDS students and another student from Faculty of Art to help with the design. And then we did the initial sourcing. We cataloged all the images, tagged them, organized them, find the links for each of them, and we identified which of them they are available, and we don't really need like any copyright or licensing thing, and which of them we are not allowed to reuse them. So we create and recreated some of the images, either because the quality was not good, or because we are not allowed to use it. And then we redesigned the booklet by getting some input from educational technology and Faculty of Art. And this is the final product. So finally, last October, and then after we finished everything, I had to meet with Copyright Office again to make sure that we have a proper copyright for the final product. And once they approved everything, then all 4 booklets are now available on the University of Alberta Education and Research Archives. So the booklets can be used either as a package, or each photo can be used individually. So it is open to public for any community access for the public, and also if people from researchers or educators from the school, they want to use it, they can use it too. So I'm trying to just access to at least one of them. So through this website, when you go here, so you see all the booklets are here. You can easily download it from the website. And I don't mind, and I understand that if you want to use any of these booklets, you want to have your own community logo, so that's absolutely fine. But you can contact me. I can help you with adding your logo to the booklet. So this is on the general knowledge. As you see, we have a preface, the story that I told you, how these booklets were developed, how you can use it in terms of the copyright, and then we try to make it as visual as possible. We minimize the text for all booklets, and these are the absolute take-home message. So if you want to include it in your community programs, this is pretty much like the take-home message that as a dental professionals we want to pass to the families. So these are like, this is the one booklet, and then the other booklets. Oh, I think I closed my. Oh, here we go. So the other 4 booklets are the same. You can go, but if you need anything from me, please don't hesitate to contact me. So the overall conclusion of this research is, first of all, newcomer children, they are at risk of developing cavities, and as they are trying to integrate into the Canadian culture, it takes time. We have another line of research looking at acculturation and social support, one of my PhD students working on it, but it takes time. It doesn't happen in the first 5 years, or sometimes even in the first 10 years. So we need, as a healthcare providers, we need to provide some support to them until they can easily navigate the healthcare system and be independent. We also need to have, and by supporting not just free dental services, but by providing more community-based interventions that are sustainable, by empowering the community, training them, then they can train the other community members. And also, what we learned from this project is we need all the stakeholders. It's not like, as a researcher, if we just do our own business, it's not going to have any impact on the problem. It's just to make us happy. But if we want to do some impactful change, we have to have all the stakeholders on place. And these are some challenges that we learned through the research of working with the newcomers. Engagement continue to be hard, but once the trust is there, then the engagement would be improved. And also we need to identify cultural diversity, and we have to be respectful. And finally, my collaborators, community partners, funders, and my research team, I don't have their name here, but a number of the students who are still my students, or they already graduated, they graduated and they are gone, they helped us with this research. So thank you very much for your attention. We do have some time for questions if you have any.
Yeah, thank you very much, Dr. Amin. If anyone has some questions, we do have time. So if you even want to verbalize your question, feel free, or you can put it into the chat. of a little bit of time.
Yeah, that's fine. I just rushed a little bit because I wanted to give some time for the questions. But I presented this in different contexts. And one thing that people ask me, like at the end, and that's why I mentioned that, like, if anyone wants to use any of these material, feel free to add their logo. It's understandable. So.
That's wonderful. And we will send out the link to the resources as well. I know when you were trying to link on the share, I think we needed to share that view and we didn't see it on our screens, but we'll send that in the email to everyone as well. And the recording of your presentation.
Oh, absolutely fine.
And oh, there's some questions in the chat. Some good comments. I love that it's in a format others can use. And how do you encourage to change the diet? Is one question.
It is absolutely hard. Like not in this project, but even like in the interviews that we had with the parents, they feel like it's okay if they give, for example, candies and then they brush their teeth. So I understood that it is easier for the parents to control the oral hygiene rather than the diet, because diet it's harder. However, even some visual, like for example, when we show them, I think in one of the booklets, we show them the sugar cube and the number of sugar cubes in one bottle of Coke, it is eye-opening for them. So sometimes writing is not as powerful as images. So that's why, like I didn't have time to go through like the others, but if there is one booklet on diet, if you go through it, we try to make it as visual as possible. So hopefully it would be.
I thought that might be a question. Someone complaining about diet. Another question is, how would you define social capital?
Very good question. Again, we had a project with one of the indigenous communities around Edmonton, and we looked at the social capital. Social capital is the strengths of the community. When we go to the communities, all we see is their weakness, right? While if we change our lens and look at their strengths, which we call it social capital, then we can use their strengths toward our promotion activities. So I haven't done any social capital project with immigrant population, but the one that we did with the indigenous community, it was very interesting. And it is even from the community perspective, instead of highlighting their problems, their issues, if you try to highlight their strengths, then that would be very powerful. That's the time you can build up trust with the community. So yeah, social capital is more like the strengths of the community.
That's great. Another question is, do you have any plans or funding to do further KTT about this project throughout Alberta or other provinces?
As a matter of fact, yes, I would love to. It took me 10 years to reach this point, but now I feel like even just having it openly available to the public is not enough. I was even thinking of I don't know, developing some apps or, like something that is more interactive. That's one way to expand. Another expansion is for the age group, because this is more like for the new parents and for children 0 to 6. In my new line of research, I'm working with adolescents 12 to 18, and man, they are overlooked. They are overlooked. There's not much research. We focus so much on like early childhood. We kind of get lost, like we forget about this age. So I am hoping to do something similar for 12 to 18, and not only for the parents, also for the children, you know. And then if it can be more interactive, then it would be even more impactful. And that's again another way of expanding this. And even in addition to these 4 booklets, I was even thinking some other aspects, like for example, trauma, you know, like it happens all the time. People are clueless how to deal with it, especially in children less than 6, like how parents should deal with it. So I was thinking to add more topics to these booklets. But these 4 are like the essential, as I said, the basic essential information that we want to transfer to the public.
So I have another question here, a very welcoming question. How can public health help your cause more?
How can public health? So I think it's enough to work in isolation. You know, like dentistry, we have been away from other health ally enough. We have to get used to. We have to get used to work with others. You know, like, and I think that's how it is much easier. Like even in the intervention, if we try to take advantage of the resources available already for the health, and then plug into some initiatives, and instead of reinventing the wheel and trying to start from zero. Because honestly, like in any grant application, people ask me, are teeth more important than heart? No, not. They are not more important than heart. So if we try to isolate ourselves, we have to compete with, you know, all issues around cancer, around cardiovascular, around. But if we work together with the public health, then it would be easier for us to take care of this piece of the body. So my expectation from public, like not expectation, how we public health can help us by accepting us, you know, like public health recognize oral health is not only dentist or dental hygienist or dental therapist business. It's public health business, and they are responsible for it.
That's great. And I know for me, I would agree with you, coming from a nutrition background, that we can all work together and have those consistent messages across the board. So I don't see any other questions here. So if there are more after the presentation, I'll make sure that we share them with everyone. But thank you very much, Dr. Amin, and everyone for joining. I'll be sending the email shortly, and also send some more information on our next presentation in the presentation series.
Thank you so much, Daniela, for organizing this and for inviting this. And yeah, I really enjoyed disseminating, and that's one way to do it. And again, if anyone wants to have more information about this educational tool, please feel free to contact me. I don't know if I forgot to put my email address on the slide, so maybe before.
I will send it out with the email to everyone too, so that we all have your contact information.